Welcome to part 1 of our explainer series on functional versus structural dizziness. Listen, functional dizziness is absolutely real, it's biologically grounded, and most importantly, it is highly treatable. So today, we're going to unpack the predictive coding mechanism, separate it completely from structural issues, and give you the exact language you need to turn a really tricky diagnostic conversation into a crystal clear retraining plan.
Right out of the gate, I want to mention that this explainer is based on the literature review titled Functional Dizziness, Physiotherapy Approaches, Behavioral Assessment, Graded Exposure, and CBT Integration, which was published by Australian Dizziness Clinics. You can find that available at australiandizzinessclinics.com.
Okay, so picture this. You've got two patients sitting in your clinic. Both are dealing with severe dizziness and both have completely normal peripheral vestibular tests, yet one of them improves steadily over 6 weeks, while the other, they stayed disabled for years. So why the massive difference? Well, it almost always comes down to one thing: whether the clinician successfully identified positive functional signs and, crucially, reframed that dizziness as a nervous system miscalibration that can actually be retrained.
So our agenda for this explainer is pretty straightforward. Number 1, the clinical challenge. 2, the predictive coding mechanism. 3, spotting those positive signs. And 4, reframing the conversation. Let's jump in.
Section 1, the clinical challenge. We really need to move beyond just looking for normal tests.
Get this, functional neurological disorders are incredibly prevalent. We're talking up to an astonishing 1/3 of all patients seen in dizziness clinics. Literally 1 in 3. So if you manage dizziness, you are seeing this all the time. Mastering this framework, it isn't just optional anymore, it's absolutely essential.
You know, historically, functional dizziness was treated as this diagnosis of exclusion. Or worse, clinicians thought it was all in the patient's head. But modern neuroimaging has completely rewritten that narrative. We can now literally see the altered connectivity in the brain's motor planning, prediction, and limbic networks. The biology is very, very real. It's a network-level brain disorder, and treating it means we actually have to address those specific networks.
Moving on to Section 2, the predictive coding mechanism. This is the brain miscalibration at the heart of the issue.
Normally, your brain is constantly generating predictions about the sensory input it expects to get from your head and body movements, right? And it updates those predictions when reality matches up. But in functional dizziness, this predictive model is totally biased. It expects a threat. And because of this threat-driven attention, the nervous system vastly overweights internal somatic signals and basically ignores or underweights the actual accurate sensory feedback coming from the environment. The end result? A persistent feeling of imbalance, even though their peripheral vestibular function is completely intact.
Now here's a brilliant way to explain this to your patients using the traffic light analogy. Imagine a perfectly safe, smoothly paved road. But the traffic light at the intersection is malfunctioning. It's flashing red and signaling danger when there literally is none. That broken light causes extreme hypervigilance. Repaving the road, treating the ear, isn't going to help at all. Fixing the light, which means recalibrating the brain's predictive model, that is what actually solves the problem.
Section 3, spotting positive signs. Let's look at the bedside battery.
Before we even start testing, we have to clearly distinguish functional dizziness from persistent postural perceptual dizziness, or PPPD. While it's true that both involve normal vestibular tests, PPPD is really characterized by persistent visual motion-driven symptoms. Functional dizziness, on the flip side, is identified by positive physical signs and some really striking symptom variability. So remember, normal vestibular tests combined with positive functional signs. That isn't a diagnostic gap, it is a definitive diagnosis.
So what exactly are these positive diagnostic signs? Well, the bedside battery includes give-way weakness, midline crossing difficulty, distractibility on dual task, functional tremor entrainment, and the Hoover sign. Let's break these down real quick. And as we do, keep one core principle in mind. Every single one of these relies on a clear dissociation between voluntary, conscious effort and the automatic, involuntary motor system. Take give-way weakness, for example. It's a classic dissociation. When you test it in isolation, the limb resists initially, but then suddenly just collapses under the load. But, and here's the kicker, full strength miraculously returns when that exact same muscle group is recruited during a functional task. Like, they might fail the test on the exam table, but then walk right out of your clinic without a hint of a foot drop. Next up is midline crossing difficulty. If you ask a seated patient to touch your finger and then their nose, and then ask them to repeat that exact movement, crossing their body's midline, say right hand to left ear, a functional pattern is going to show a distinct hesitation. They might abort the movement entirely or show this wildly disproportionate effort exactly at the midline crossing. Now, if this were structural like cerebellar ataxia, you'd see uniform incoordination throughout the entire movement, not just a failure specific to the midline.
Distractibility on dual task is honestly fascinating. Give a dizzy patient a competing cognitive task, something like counting backward by sevens or naming animals. Just watch their functional symptoms diminish or even vanish completely. It happens because the functional pattern actually demands conscious attention to exist. Remove that attention, and you literally remove the sign. Structural movement disorders, on the other hand, actually intensify under a dual task because you're stripping away their compensatory attentional control.
And then, of course, there's the Hoover sign. Ask your supine patient to lift their affected leg. In cases of organic weakness, their unaffected heel will involuntarily press firmly down into your hand. But in functional weakness, it fails to press down. This crystal clear dissociation between absent voluntary effort and intact involuntary synergy is totally pathognomonic. It absolutely confirms a functional component.
Section 4. Reframing the conversation. How to actually use language as therapy.
The way you deliver this diagnosis is literally an active part of the therapeutic intervention. You have to aggressively avoid the term psychogenic. It falsely implies this dismissive mind-over-matter situation, and it will instantly damage your therapeutic alliance. Instead, always use the word functional. It conveys legitimacy that their symptoms are 100% real and reversibility, signaling that this network miscalibration can absolutely be retrained. And demonstrating those positive signs from the bedside battery directly to the patient during this chat, that proves to them right then and there that their automatic systems still work perfectly fine.
Open up with the neurobiology. Tell them confidently, your nervous system is misinterpreting sensory signals. Don't hedge, don't be vague. Your explicit, confident communication is the absolutely crucial first step. And that sets us up perfectly, because in the next part of this explainer series, we'll move straight into the bedside positive sign battery, the threat perception screen, and how cognitive techniques weave directly in your physiotherapy sessions.
So, before you see your next dizzy patient, ask yourself, are you just ruling out the structural, or are you actively looking for the functional? For additional resources, including the full literature review, the clinical cheat sheet, audio overviews, and the rest of this explainer series, visit AustralianDizzinessClinics.com. Please subscribe to the channel and leave a rating to support the series.